coming. So I have the pleasure, I guess, of being the last grand rounds for the year. So thank you so much for coming to my talk. As you can see, my talk will be focused around hemodialysis vascular access. PD will be next year. Just kidding. All right. So learning objectives for today. So I was going to review just kind of the chronological history of the advancements of hemodialysis access, obviously review present-day modalities, briefly discuss the diagnosis and management of common flow and non-flow related complications of access, as well as briefly review the Kadoki guidelines regarding surveillance, and then lastly just talk about a few emerging innovations that are coming in vascular access. So, as a disclaimer, this image was generated with AI. None of the images for the rest of the talk are AI based, but this is just kind of a general overview, and I'm going to go more in depth with each of kind of the advancements of each decade. And so, I kind of thought, one of the reasons why I wanted to do this talk was, I think it's important for us to be familiar with kind of the advancement of vascular surgery along with our own field of nephrology. And we'll be inundated with vascular complications, be exposed to access all the time, of course, in the ESRD setting. So I think it's important as fellows to be at least familiar with the history as well as all the complications associated with vascular access. So we're going to start in the 1920s. Pictured here is Dr. Haas, who is here on the right side. So this is a picture taken back in 1926. And so, I think we're all familiar with Dr. William Culp, who's considered like one of the forefathers of hemodialysis. But in the vascular world, Dr. George Haas is actually considered one of the founding fathers of hemodialysis access. And so he's pictured here with as well one of the vascular surgeons, Dr. Fritz von der Hutten. And so together they worked to perform vascular connection between the radial artery and the cubital vein, and they actually used glass cannulas or glass tubes. Unfortunately, the vascular access when they would use it was only sufficient for one dialysis session, and so essentially the access would be completely destroyed after they did one dialysis session. And so glass cannulas were continued to be used even by Dr. William Culp. But this was kind of the start to show that, okay, short-term dialysis was possible, but obviously some change was needed in order to allow us to perform long-term dialysis. But this present modality obviously could not be done indefinitely. Interestingly, the dialysis membrane that they were using at this time was made from collodion, which, if you guys don't know, is a form of nitrocellulose, which actually later became rocket fuel. So just a fun fact. So now jumping ahead 40 years, we go to Dr. Scribner, Dr. Belling Scribner. So he's credited in vascular surgery as kind of another forefather. And so he created the Scribner shunt, pictured here on the right side of your screen. And so this is essentially an external U-shaped shunt that was made from Teflon. And so he had actually expanded upon this idea from another doctor in Sweden, Dr. Alwall, who at the time, instead of using glass cannulas, he was using rubber tubes coated with silicone as his dialysis access. And so he thought, well, why shouldn't I use Teflon? And so the Scribner shunt went from the radial artery to the cephalic vein, and then allowed dialysis to be performed without directly accessing the patient's vessels with each dialysis session. And so again, this is a major advancement in the vascular surgery world. Now, jumping a few years later, specifically in 1966, we have this group of physicians at the VA hospital in the Bronx. Pictured here are Dr. James Camino on the right side, who was the chief of nephrology at the VA Bronx Hospital at the time. We have Dr. Charles Appel, who was one of the vascular surgeons, and then Dr. Brescia, who was also a nephrology attending at the time at the VA hospital. So again, off the back of Dr. Scribner's innovations, nephrology and vascular surgery were trying to find better alternatives to external shunts. And so Dr. Brescia and Dr. Camino were experimenting with using percutaneous venipuncture using 12 to 16 gauge needles. They would actually be accessing a forearm vein, connecting it to the dialysis machine at the time, which is the artificial Culp twin coil kidney machine. And then they would return the dialyzed blood through another needle, which is actually typically accessed in the ankle at the time. Now, the issue with this is, in order to facilitate high enough blood flow rates to perform the dialysis, they would have to essentially just pump these people with IV fluids to make them hypervolemic in order to achieve adequate access flows. So eventually they called in Dr. Charles Appel, vascular surgeon, to see, is there anything better that we could do? And so he had created the internal fistula. So this is just a brief diagram of, the fistula, and I have a picture from their actual New England Journal of Medicine article that they had published. So like I said, in 1966, this was kind of the first successful internalized fistula. So Dr. Appel would perform a 3-centimeter incision over the radial pulse. He would then mobilize the radial artery along with the radial vein, and then smaller longitudinal incisions would be made, roughly about 0.5 centimeters, 1/5 of an inch, along the vessels in order to create a side-to-side anastomosis. And so you can kind of make out stitches here. Now, at the time, they had 16 patients on their census at the VA during that time, and they were successfully able to create internal fistulas in 13 of them. And then these doctors went on to publish their research in the New England Journal of Medicine. But again, this is another major advancement just 4 years later after the creation of the external AV shunt. These internalized fistula obviously had better long-term patency, lower infection risk. And then again, because it was subcutaneous, they didn't have to have this piece of hardware that the patients walk around with. And then this is just the original article that they published. So November 17th, 1966. Interestingly, I looked at the other issues that were in this journal at the time, and the other major advancement was the use of nalidixic acid, which is a precursor to fluoroquinolones. So just amazing to see how much medicine has advanced in a century. So jumping ahead to the 70s to the 90s, we have the synthetic revolution. Now, unlike the previous fistulas, internal fistula, external fistula, I wasn't able to identify one single credited inventor of our synthetic grafts. But the revolution itself came from the innovation of something called PTFE, which some of you may know as polytetrafluoroethylene. This later, during the 70s, became commercialized as expanded PTFE. And the field of vascular surgery was rapidly advancing at the time, and they were already using this synthetic material to make prosthetic vascular material for bypasses, aortic repairs. And so same thought process was applied to hemodialysis access. The field further advanced to then the availability of central venous catheters, which came during the 80s. But the benefits of using polytetrafluoroethylene was that it was chemically inert, it was less thrombogenic, and then it was more durable, flexible, but also had a micropore structure to allow for tissue ingrowth replacement. And for those of you that may not know what expanded PTFE is, it's Cortex. So that was the major advancement that came during that time. So that brings us to today. So we went through 20s, we went through the 60s, 70s through 90s, bring us now to the 2000s. So, I'm not going to belabor the point too much. Obviously, we're all familiar with internalized AV fistulas, the non-autogenous AV grafts. And so this is a graphic that I got from JAMA, but essentially, I thought it was great to include because it just kind of shows all the different sites that potentially could be used for fistula placement. As you can see here, we can go all the way down to the anatomic snuff box, and then all the way up more proximally here. And then similarly, here's just a nice picture of what an AV graft would look like. But just in general, from the vascular surgery side, they say that an acceptable cannulation zone should be straight, obviously, be around 8 to 10 centimeters in length, close to the skin surface, and then should be located on an extremity that can be comfortably placed during dialysis. As we all know, obviously, being able to withstand that for 4 hours. And most common, as we know, is going to be brachiocephalic, radiocephalic in terms of fistula placement. All right, so again, this is another picture from JAMA. And it's just comparing the different combinations as well as complications associated with each of the access types specifically for hemodialysis. So I know that we're all familiar with this, but just to kind of drive the point home, as we all know with fistulas, the downside is obviously a longer maturation time, typically 2 to 6 months, sometimes longer. The issue with fistulas is that sometimes they may need multiple interventions in order to maintain or establish patency. And I'm going to discuss the different complications associated with each of the dialysis access. Then obviously we have the CVCs here. The biggest complication other than infection is going to be central venous stenosis, which I'm going to address on the next slide. But overall, Yeah, that's the only point I want to make here. All right. So next is the hero graft. And so this is an innovation that came out within the last decade or so. And so I wasn't really familiar with it, and I had witnessed it for the first time this year, and that was kind of the part of the reason why I thought about making this talk. But the hero graft also stands for hemodialysis reliable outflow graft, and it is essentially a hybrid vascular access device made for patients that have central venous stenosis or occlusion. And then they've also exhausted all other conventional upper extremity options. So the benefit of using a hero graft over a traditional AV graft is that it's able to bypass the obstruction by connecting the brachial artery to the graft itself, and then it bypasses the venous outflow component and goes right into the SVC and right atrium. And again, there's no venous anastomosis, which is another thing that distinguishes it from your conventional AV grafts. And then again, primary indications for its use is just someone that has central venous stenosis, typically from a long indwelling CVC, or someone that has exhausted all other options possible. Right. So before jumping into the different complications associated with vascular access, I did kind of want to briefly talk about the plan paradigm, which is an update that came from the 2019 KDOQI guidelines. So essentially what the plan approach or plan paradigm is, plan stands for patient life plan first, followed by access needs. So that's seen here on the side. But this is an update from the previous KDOQI guidelines, which focused primarily on placing fistula first, asking questions later. This 2019 approach changed that, and it now becomes more of an individualized approach in conjunction with the patient's plan for their life and what they want out of their life. And so this philosophy, in essence, is trying to achieve the goal of placing the right access for the right patient at the right time, and also for the right reasons. So these are some cases from the NKF that kind of highlight this plan approach. And so, I'm happy that I don't do pediatric nephrology. That'd be very tough to have these conversations. But, here we have a 14-year-old girl. She has a congenital cause of CKD. She's not currently on dialysis. She has a living donor for transplant, and she has life goals of wanting to become a teacher, and she's right-handed. So going through the life plan, this is her life plan here. Now, what would be kind of ideal scenarios for her kidney disease? Now, obviously, the first choice would be having a living donor transplant, but secondarily, perhaps maybe doing peritoneal dialysis or home nocturnal hemodialysis. And kind of following this plan, doing transplant first, then PD catheter if transplant is not an option, and then lastly would be a radiocephalic AV fistula on her left hand. So again, the recommendation is to follow closely with her. Follow her. She's anticipated to have a long life. But always keep in mind, as nephrologists and investigators in conjunction with vascular surgery, we should remain flexible to her and how her life plans could change. Now, contrast this with this gentleman, which I think all of us fellows and all of us attendings are very familiar with this, how should I say, protoplasm or type of patient. Essentially a 48-year-old gentleman, type 2 diabetes, hypertension, obese, non-adherent to medical therapy, works in outdoor maintenance, not urgently needing, he does need urgent start hemodialysis. So ideally for him, in discussion, his ideal start would be in-center hemodialysis, waitlisting him for transplant. PD may be possible. Some people might disagree, but in-center would be his preferred. And so along those lines, thinking that an AV graft, because it is more readily available for use than a fistula, perhaps an AV graft for him would be the better route of access. Secondarily would be a brachiocephalic AV fistula. And then lastly, on the totem pole would be a PD catheter.
I'm so sorry. I didn't want to, but who decides this 1, 2, 3?
No, this is just an example.
But in that example,
in this example, this is in conjunction with nephrology, the patient, and vascular surgery. But I think the emphasis is that you lay out all the options for the patient. You learn about his life, his conditions. Like I said, for some people, maybe PD would be first, and center would be third. But in this specific example, they felt that in-center hemodialysis would be the best option for him.
We'll talk about when you are wrapping up this. I think that this particular guidelines have created a bunch of issues.
Sure.
At least for people, at least for me, at least I would say in that way. It just is that I think there is a very poor understanding within the guideline and outside the guideline. What is that third column supposed to be, and who decides that? And I think that there is a huge problem with that.
Sure.
Anyway, I'll let you go ahead.
Yeah. All right. And then this is just the last example, just to drive the point home, but we've also experienced this many times, right? 88-year-old gentleman, multiple comorbidities, coming in very sick, severe AKI, needing to start dialysis. Ultimately, his goal is, at the end of his life, is just to try to spend as much time as he can with family. And so with that life plan in mind, it was decided that, okay, in-center hemodialysis would be the best option for him.
You mean patient decided?
Yes, patient and nephrology, yes. Decided.
This is not patient. Like in their guideline write-up, this is very.
Did they say that this is patient deciding?
These are just examples. Like this is not like a specific case.
Right.
It's just, yeah.
So to their understanding, the patient shipping to a dialysis unit in a bed is apparently more within that particular definition of palliative patient with very frail, rather than that person doing PD at home, for example. And that's the whole problem with that guideline, because they bring up the issue of shared decision making, but their examples never include shared decision. They have this very obtusely mentioned. It's a whole topic. I'm sorry.
No, it's okay. It's okay. I appreciate the discussion. But essentially, in this gentleman, it was decided that with him, patient preference is for a central venous catheter over a fistula, or possibly a graft as well, but CVC first. So that concludes that objective. So now I'm going to be talking about complications of vascular access. So again, I went through all the different progress that we've made, specifically in nephrology and vascular surgery over the last half century, actually a century at this point now. But as we all know, the reality is no access is without complication or limitations. And so I think another reason why I wanted to do this topic as my grand rounds is education for myself, but also maybe some education for my co-fellows, just about how we can recognize certain complications of vascular access. And so in these next few slides, I want to go over the most common complications, both flow and non-flow related, as well as discussing the diagnosis and briefly discussing the management. Without further ado. So I'm going to open with just the general case. So this is a 68-year-old man, hemodialysis patient via left radial cephalic AV fistula, presenting with prolonged bleeding after dialysis for the past 2 weeks, difficulty achieving target blood flow rates. On examination, the fistula has a weak thrill, high-pitched bruit near the antecubital fossa. In the middle of your screen here are the different ultrasound studies. So I'll let you guys just absorb that for a little bit, and then I'll go on. But essentially the question I posed is, what is the most likely diagnosis and best step for management? So, again, this is a very common clinical scenario that we've all encountered. And so the first complication I wanted to discuss was obviously AV access stenosis. So this is the most common complication of AV access, and it's the leading cause of access thrombosis. It results from progressive neonatal hyperplasia that typically occurs at the venous anastomosis of AV grafts, or at the juxta anastomotic segment or the outflow vein in the AV fistulas. Now, this is a picture here that just lists all the possible sites of stenosis, but outflow stenosis can occur anywhere along the course of the anastomotic vein segment, from the heart all the way to the cephalic arch. Arterial inflow stenosis is less common than outflow stenosis in both fistulas and grafts. And then, like I said, the most common sites for stenosis and grafts are the venous anastomosis. Now, this is a table that just reviews different physical exam findings that we could find on exam prior to dialysis as well as during dialysis. And so I thought this was a great chart that would kind of highlight these points. Outflow stenosis is typically characterized by hyperpulsability at the anastomosis. And then when you do the arm elevation test, there'd be failure of the fistula to collapse when the arm is elevated above the heart. Now, during dialysis, we can often see elevated venous pressures with no change in blood pump speeds. Compare this to inflow stenosis, which typically is characterized by a lack of decreased pulse augmentation, and then excessive collapse of the vessel segment on arm elevation. On dialysis, you may see pressure monitors indicating a very high negative arterial pressure. And then just kind of general signs on physical exam of AV stenosis would be, ipsilateral extremity edema, a weak pulse pulse that is difficult, a difficult to compress area of the stenosis. There can be an abnormal thrill that's either weak or discontinuous, and then an abnormal bruit. And then on dialysis, they can either present with new difficulty with cannulation, they can have aspiration of clots from the access, and then again, inability to achieve target dialysis blood flows. They can have prolonged bleeding as well. So with regards to the diagnosis, obviously after clinical exam, the diagnosis then comes with confirmation with duplex ultrasonography, which is considered the first line confirmatory imaging modality. Now, in terms of differences between how ultrasonography would present with the different types of stenosis, in regards to inflow or arterial stenosis, you would see a tardus parvus waveform in the feeding artery distal to the stenosis, whereas outflow venous stenosis would be mostly identified by elevated velocities and then a high peak systolic velocity ratio greater than 2:1. And so that was illustrated in that case there. Here, the peak systolic velocities. Okay, now, in regards to management, now, I'm not a surgeon. I'm not going to go too far deep into the surgical procedures of how we manage it. I just thought it was important that we're at least familiar with the different types of management that can be done for each of these complications. So first-line therapy, as we're all familiar, would be percutaneous transluminal angioplasty with balloons, but there's also more data coming out about using drug-coated balloons. But current vascular surgery guidelines say that first line is just doing transluminal angioplasty with the balloons. If they have recurrent stenosis within 3 to 12 months, then the decision then becomes, do we do a repeat angioplasty with the balloon or use drug-coated balloons? And then open surgical revision is only considered once these endovascular therapies have been exhausted. And I hope that you guys can see this in the back, but this is just an example of what balloon angioplasty may look like for management of AV stenosis. So the next complication I wanted to discuss, kind of piggybacking off of stenosis, is thrombosis. And so I've seen this a few times, definitely throughout the fellowship here, but thrombosis, important for my co-fellows to know, is more common in AV grafts compared to fistulas. And the most common etiology is underlying AV stenosis. And so you should suspect a thrombosis if you're palpating the fistula or the graft and you don't feel a thrill or bruit at all, or if there's inability to actually cannulate on dialysis. And so the first alarm bell that should be going off is there a thrombosis of this access? Similarly, diagnosis is mainly clinically, but confirmed by ultrasonography. Ultrasonography would show an absent flow on the duplex ultrasound. And then, as we all know, time is of the essence with regards to thrombosis of these AV access, because after 72 hours for fistulas, it can become non-viable compared to 5 days for AVGs. And then again, with regards to management, again, endovascular is typically first line. And so, get IR involved for mechanical thrombectomy or pharmacologic thrombolysis. And then again, surgical thrombectomy is required if these endovascular attempts fail. All right, so I've gone through stenosis, I've gone through thrombosis, which are the most common flow-related access complications. So now I wanted to bring a different question now, which is a clinical scenario. So this is a case of a 58-year-old gentleman, history of ESKD on hemodialysis via a right IJ CBC on a Monday, Wednesday, Friday schedule. He also has a history of hypertension, type 2 diabetes complicated by neuropathy, hyperlipidemia, as well as peripheral arterial disease. He presents to the hospital for left BC AV fistula creation with vascular surgery. You were consulted for quote-unquote routine ESRD management and continuation of hemodialysis while he's inpatient. And so this is a common consult we get all the time, especially on the VA service. And so we see these patients, typically post-operatively. So in this scenario, you're seeing him about 1 hour post-operatively. He's complaining to you of constant severe burning, left hand pain and weakness, physical examination, as you can see in the picture there. But also he has intact distal pulses, capillary refill is normal. So which of the following is the most likely cause? Is this a pseudoaneurysmal formation? Is this access-related hand ischemia? Is this ischemic monomellic neuropathy or carpal tunnel syndrome? Right, so I'm going to go through each of these modalities, specifically the first three in the next few slides. So first topic is access-related hand ischemia, also known as vascular steal syndrome. So this is a complication that's estimated to occur in roughly 1 to 20% of patients after AV access creation. Only around 10% of them require surgical intervention. And so this is considered a non-flow related access dysfunction. I did see in one vascular surgery journal, it said that in a registry of around 35,000 people that had access creation, severe hand ischemia occurred in only roughly around 2.7% of patients. So diagnosis of access-related hand ischemia is mostly clinical. And so it is manifested by cold skin, cyanosis, numbness, weakness, or even digital ischemia in severe cases in the extremity that is distal to the access. I think a very important caveat for my fellows to also remember is that these symptoms can be present only during dialysis, but a cardinal sign is they're worsened during dialysis. Okay, so that's something to think of for us when they're complaining of these symptoms. The symptoms can improve with manual compression of the AV access. And then after clinical exam, if it's suspicious, diagnosis can be confirmed with non-invasive arterial testing, whether that's with ultrasound or with brachial radial artery pressure measurements. And so this picture, as you can see here, she has a AV access on her left extremity, and she has some digital ischemia. And then here, this picture doesn't really do it justice, but you can just very subtly see paler of the left hand compared to the right hand. And so just something for us to keep in mind. Now, again, like I said, the diagnosis of access-related ischemia, the cardinal sign is that the symptoms will worsen while they're on dialysis. Duplex ultrasonography can help to assess for the presence of arterial stenosis or occlusion. But the key feature is demonstration of retrograde flow from the distal artery going into the AV access, and that's highly suggestive of access-related hand ischemia. And I don't think we do this anymore, but just wanted to throw it in there. You know, if ultrasounds are not available, you can do some digital brachial arterial testing, and the index would show a ratio less than 0.6. And so this also can be suggestive of ischemia related to the access. Now, at least with regards to vascular surgery, they have a different grading of access-related hand ischemia. So as you can see here, grade 0, very symptomatic. There's no intervention necessary. Grade 1 is identified by a patient that has cool extremities, but it's considered mild symptoms. Now, I tried to find, you know, what is the difference between mild, moderate, severe. They didn't really outline what, you know, how they delineate each of those things. But it says surveillance only, and you can do conservative measures. So I saw that some measures could be done, like wearing warm mittens while they're on dialysis, and then doing our best to avoid hypotension while they're on dialysis. And then lastly, for patients that are considered grade 2 or grade 3, in terms of hand ischemia, surgical referral is mandatory. Okay, now again, I'm not a surgeon, but I just wanted to kind of include just the different types of procedures they could potentially do to correct access-related hand ischemia. From what I could find, the drill procedure, which is drill stands for distal revascularization with internal ligation, is considered first line for management, surgical management of access-related hand ischemia. And so essentially what they do is they create a bypass between the arterial segments that are proximal and distal to the AV stenosis, as you can see here. And then they ligate the native artery between the AV stenosis and the distal stenosis of the bypass. So that's how they're able to restore proximal flow. The other modality is Rudy, or revascularization using distal inflow. And so the surgeons will actually create a conduit to connect the AV outflow vein to a more distal vein with ligation of the original fistula. And this will lead to a fistula that has lower flow with higher resistance, which can help mitigate the ischemia. And then lastly is the PAI procedure, which stands for proximalization of arterial flow. Similarly, they use a conduit to reroute inflow proximally, which will defunctionalize the original anastomosis and then make the new functioning access more proximal, which again works to alleviate these symptoms. Okay. This is just the table reviewing those previous surgical therapies that I highlighted, but here I think what I wanted to illustrate here is just, and this is being blocked. There we go. So symptom resolution and patency, I think, was the thing that I wanted to highlight here. So for the drill procedure, which is considered first line, they cite that at a 1 year post-operatively, they have primary patency of between 55 and 95%, which is a huge huge range, but it does work to resolve their symptoms in up to 98%. Now, for patients that have considered high flow access-related hand ischemia, they sometimes don't have to go through these different surgical modalities. Instead, they can do what's called banding and plication, which is kind of almost similar to like gastric bypass. Essentially, what they do is they just wrap a synthetic cuff around the conduit, and that's the banding portion. And then the plication is using a running stitch to narrow the vessel lumen near this anastomosis. And so that modality is typically done for AV fistulas as opposed to AV grafts, since AVGs require higher flows in order to maintain patency. So banding is not really useful for graft patients. All right, so this is a very extreme example of an aneurysm related to a fistula. Now I haven't seen anything this severe. I hope I don't, but in my career I may. But obviously very important for us to recognize aneurysms before they get to this severity. And so it's estimated that roughly 40 to 60% of all AV fistula patients are in some way affected by some form of aneurysmal dilatation, with the primary risk factors being ongoing outflow stenosis, as well as repeated same site cannulation during dialysis. So physical exam obviously would show visible vessel dilatation, but more subtle signs might be that the skin is just shiny, hypopigmented. It can appear ulcerated. And then one kind of subtle marker is the inability to pinch the skin overlying the fistula, and that can kind of be the first sign that there's aneurysmal formation going on. Again, like all these, a lot of these complications, the diagnosis first should be suspected clinically and then confirmed with ultrasonography. And so in this case, the importance of it would be to assess the size, flow, and evaluate for outflow stenosis. And then beyond ultrasound, catheter-directed venography can be done in order to also assess for concurrent outflow stenosis. This picture here I wanted to include because it shows an eschar. And so if there's an eschar in a patient, that could be kind of a danger sign for impending rupture. And so if you should see that, it may warrant emergent evaluation. Okay, so briefly on pseudoaneurysms. So pseudoaneurysms is typically a complication that's associated with AV grafts over AV fistulas, and it comes due to repeated punctures leading to AV graft degeneration. And this occurs because typically only the overlying skin and subcutaneous tissue are barriers to bleeding. And so this makes AV grafts more prone to bleeding. And so because of this, cannulation at the site of the pseudoaneurysm should be avoided to avoid rupture, obviously. And then surgical treatment is indicated either if the pseudoaneurysm is enlarging or if they have multiple pseudoaneurysms that are repeating flow, or lastly, if there is an underlying graft infection, which I will talk about a little bit later. All right. Now, bringing us to ischemic monomelic neuropathy. This is considered a very severe manifestation of access-related hand ischemia. And the classic presentation is within hours of AV access creation. So it's estimated to only occur in roughly 0.1 to 0.5% of all AV access patients. And again, the major manifestation is severe constant burning pain in the distal forearm or the hand after brachial-based access creation. It can be associated with sensory loss, hand weakness, paralysis. But the reason why this diagnosis is missed is because typically the exam is normal other than the weakness. They'll have intact distal pulses, capillary refill would be normal. And so the reason for why this happens is that it's suspected to be caused by acute shunting of the blood after the access creation, which leads to distal hand nerve ischemia and axonal loss. So again, we often misattribute this pain to regional nerve blocks, just normal postoperative pain, or in our patient, he had pre-existing neuropathy. So just important to keep in our mind, especially after we're seeing these patients on the VA or in our career. And so if this is identified, call a vascular surgery and say, hey, this access needs to be ligated immediately. And it needs to be done as soon as possible in order to prevent permanent sensory motor loss and weakness. And so go to our question. That was just what I was trying to illustrate. All right. So high output heart failure is another complication that we're all familiar with. The true incidence of high output heart failure is unknown in our dialysis patients, especially since, and it's likely to be underreported since heart failure is so common in our patients with ESKD. It's associated with high flow volumes, more so associated with brachial artery-based access, and then anastomotic lengths that are greater than 4 to 6 millimeters. can be another risk factor for development. Now, definitive diagnosis is really only made if we're able to demonstrate improvement in cardiac function after surgical interventions have been done to reduce circuit flow volumes. And then ligation is commonly done in patients who no longer require AV access, like our kidney transplant patients.
Have you seen that they sometimes do the occlusion with blood pressure cuff and see the indexes?
I didn't read about that.
On the heart and see if it changes the cardiac output based on the occlusion of the fistula that gives them ID. I don't know how much is the literature on it.
At least in what I was reading, they didn't get it.
Like a functional assessment before.
But I guess exactly like that could just be kind of like if your suspicion is high, you do that, and then that could be more likely to suggest. Yeah.
In terms of aneurysms, the dilation obviously of the aneurysmal area is probably one of the most visible signs. But if you cannot pinch the skin over, that's when you lose tunicate media. Right? That is much higher risk for rupture. That's something you should really watch for. That's something that's urgent or to vascular. Right? So not being just for the fellows, you guys not being able to pinch the skin when it's shiny and stretched, or if there's an scar. This would be very, very scary signs. For these people, this is like obstetric level bleeding, right? Within a couple of minutes, the patient can lose half of blood and pass away. And this happened before, fortunately, which is how we learn, right? Sometimes we learn on scary examples.
So
you can explain the second point. Why when you have more liquid anastomosis that can increase risk of high Isn't it that you have short anastomosis that gives you more blood flow from the heart to the venous system? You're not talking about the width, you're talking about the length.
It's the length.
Yeah.
I don't know exactly, but I would imagine it's just related to it causes higher flows. So I'm not sure. I'll get back to that one.
There have been several recent cases of this as well.
Of the higher anastomotic lengths.
Higher heart failure in patients with fistulae.
All right. So this is just a table I created that just very briefly discusses infectious complications. Now, I'm not going to belabor this point too much. I think that infection by itself can be its own grand rounds. We're familiar with all of the clinical features of infections. Most commonly associated infection with each of the access sites are Staph aureus. I think the important point that I wanted to make here was that with AV grafts, often IV antibiotics by themselves are not enough. So they often need surgical intervention as well in order to completely eradicate the infection. Okay, so we've went past the complications. So one thing I wanted to kind of review is, going over all these complications, is there any utility in kind of doing routine surveillance of our fistulas? And so I think that previous guidelines back in 2006 said that we were doing routine ultrasonography for the fistulas to look for these, but the most recent Kudoki update from 2019 now found insufficient evidence to recommend routine surveillance of AV access. So really it's just a clinical diagnosis first. If you suspect it, then you confirm with ultrasound. And so, as we should at every dialysis patient, at every session, we'd be clinically monitoring their access. If we identify that there's abnormal findings, such as a loss of a thrill, full-on bleeding, difficulty cannulating, swelling, or if there's decreased dialysis adequacy, then okay, that's suspicious for a potential AV access complication. Do the duplex ultrasound. If there's hemodynamically significant stenosis or some other complication, then you would proceed with angioplasty intervention. And so at present, the Kudoki guidelines do not recommend routine surveillance. And then looking ahead to the future of vascular access. So, in a digital world, we have so many things that are coming out now. Obviously there's now movement towards using AI to do vascular access planning or vein mapping. I found an article here where this group had used a 3D printed vascular grafts, completely made to the exact dimensions of the patient's vessels. And the person's been successfully getting hemodialysis through this AV graft since 2022. Now, another promising advancement is the use of mesenchymal stem cell based therapy, specifically adipose-derived and gingival stem cells, which have been shown to have how should I say, anti-inflammatory properties that can help with promoting patency of the fistula. So there's ongoing trials now using that. And then, of course, like I said, the prevalence of AI. So there's also currently, I believe, phase 3 trials going on for biochemically engineered grafts as well, different from the 3D printed grafts. So things are continuing to advance, and over the next 10 years, we may see even more advancements in this. It could be a new grand round. So that's all I have for today. I also want to say thank you and congrats to my grads. Here's a picture of all of us. I included each of them. Any questions? Right.
Yeah, that's great. Thank you very much.
Thank you. Oh yeah, yeah. Do this one.
That's not the reference. Oh.
You want to do like the title stuff?
Very professional.
Yeah, a couple of minutes. All right.
Thank
What is your opinion before I do?
you.
Yes. Since the way serious, and I really feel over state.
And yeah, that's my figure. I was gonna think of Sure.
Fantastic.
Oh, I see. Because it's longer, then there's more profit. I see. Ah, I see.
Is that one of that? The ratio.
That makes sense.
Continues to
Thank you.
blah, blah. However, I have been uncomfortable with the fact that the ratio continues to stay high. So I went ahead and did a CT. Nonetheless, yeah.
I see.
And it does show that there is a gland.
I love it.
Something.
Thank you so much.
Like, in terms of like, one her excellent blood pressure control, persistent this, and would you pursue sampling, and what would you do?
Wow. Yes, exactly. Oh, thank you so much. Yes.
Just to give you an idea, before she came to me, about 15 years of population. I know it still is not single-agent, but it is functionally behaving like primary, just primary, although
Thanks so
still
much.
responsive.
Nice to meet you. Thank you.
Yes.
Right. No, it's good, Frank's good. But my point is, I mean, she still may need other antidepressants because of my